Assalamu alaikum. Today a new lecture with education in North Syria, step-by-step continuous medical education for neurology staff. Today with us Dr. Saima Ahmad, interventionalist neuroradiologist in Pakistan. Today we'll give about broad information about neuroimaging in stroke. Dr. Saima, you can start, and if anybody have a question, he can put in Q&A, and in the end, in the lecture, we can ask Dr. Saima. Dr. Saima, you can start.
Thank you very much, Ahmad, for this kind introduction and for having me on this prestigious forum. It's always been a pleasure to be here with you guys. So today I'll be talking about the neuroimaging in stroke. And the first of all, what is the goal of the stroke imaging? The goal of the stroke imaging is to identify the patients who can be safely treated. So obviously it can be done by ruling out the intracranial hemorrhages and by identifying the large vessel occlusion. And also we have to see the early ischemic changes. So the small core is ideal, and the core can be identified by the aspects, and which should be more than the 6, and the volume 50 to 70 ml. And we will be talking more about this volume thing later in the lecture. So whatever you are doing in the realm of the imaging, you need to be very, very fast, because after every 1 minute, 1.7 million neurons are dying. So the information you are getting by doing the imaging is at the expense of the time. So time is very important in this, and one has to be very cautious while doing the imaging, that one shouldn't waste the time. So the objectives of the talk is to get the overview of the stroke imaging using the CT and MRI. And I'll be sticking to the American Heart Association guidelines regarding the stroke treatment, and which were updated in the 2018. And throughout my presentation, I will be using these guidelines. So how imaging is used for the treatment selection in the acute ischemic stroke patients, in the thrombolysis, also in the endovascular treatment. And then we will be talking about the neuroimaging in the young acute ischemic stroke patients, few points about the pediatric strokes, and also about the stroke mimics and the neuroimaging in the advanced atherosclerosis. So when the patient come to the emergency room with a suspected stroke, what imaging modalities we can have? So obviously the first imaging we can do is the CT, because it is widely available, it is easily accessible, and everybody has the CT. We can also do the MRI, provided if our institution has the MRI facility, which is available at the 24/7. And also the institution has the kind of the protocol in which you can do it very easily in a shorter time. And the third choice is the direct to the NGO suite choice, in which both imaging and the treatment is done at the same time. It seems to be futuristic, but there are many centers who are using this approach, and we will be seeing this much more in the coming years. So why MRI in the acute ischemic stroke? We have a couple of advantages of doing the MRI in the acute ischemic stroke. The number one, it is the most sensitive method by which we can have the accurate estimation of the ischemic core, and we own this to the DWI imaging. And also we can have the accurate diagnosis of the mimics, which are a diagnostic challenge in the acute ischemic stroke, and hence also the management challenge. So the stroke protocol for MRI, they constitute of the DWI, they constitute of the FLAIR, and the gradient imaging is obviously done to rule out the intracranial hemorrhages, and then the perfusion imaging, and also the MRA to look at the aortic arch and also the intracranial vessels. So as I have already said, that DWI is the most accurate and the sensitive imaging modality for the acute ischemic stroke. It can detect the stroke as early as in 11 minutes. For example, in this case, you can see that we cannot see any of the ischemia in the non-contrast CT. However, the restricted diffusion is seen in the DWI. And it is also excellent for the tiny basal stem infarctions. You can see different examples in which you can see the brainstem infarctions, posterolateral area. Here is the infarction and here is the infarction. So you cannot diagnose these brainstem infarctions on the CT. And the DWI, the one of the other advantage of the DWI is this, that you can also identify the stroke mechanisms. For example, if you have the bilateral stroke in both cerebral hemispheres, the source may be embolic, or the border zone is involved at the watershed area, it could be the border zone. And similarly, the small vessel and the large vessels can also be identified. As far as parenchymal imaging is concerned, we go with the FLAIR and the gradient imaging. Obviously, the gradient imaging is done to rule out the hemorrhages, and the diagnostic performance of the GRE is just similar to the non-contrast CT in diagnosing the hemorrhage. And also the GRE is very much specific in identification of the subtle subarachnoid hemorrhages as well as the parenchymal hemorrhages, and you can see here. And we can also identify the clot by the parenchymal imagings. You can see in this example that in the CT there is the clot which is seen in the right MCA distal M2 territory, and you can see the clot here. So these are the advantages. So how about the MR perfusion imaging? In the MR perfusion imaging, we need to see the core and the penumbra. So the core is already identified by the DWI. This is the added advantage, that we already know through the DWI that where is the core. So this is already the core is there. The second part is the penumbra. We just need to identify the penumbra in the MR, and which is actually the Tmax more than the 6 seconds. And so hence we can identify the core and the penumbra very easily with the MR perfusion imaging. So this is one of the example in which you can see that there is the restricted diffusion in the left posterior parietal region, and this is the perfusion imaging in which you can see there is a large penumbra. So if you do not go for the treatment or EVT in these cases, you can see that it is converted into the ischemia after the 24 hours. And if you compare the size of both this penumbra and the in the core, you can see that the size is the same. So this happens if you do not treat it. So why the MRI is underutilized after all said and done, and after all these advantages? When it is a selection criteria in many of the previous trials, which are both open for the MR and CT. In the diffuse 3 trial, which was completed like few years ago, only 25% of the patients are enrolled by the MRI, though they can be enrolled both by the CT and MRI. After all the advantages, we have few limitations. Obviously, there is a limited access to the MRI. There is 24/7 the MRI is not available, and also there is a disruptive workflow when using the MRI. So all institutions, when they want to use the MRI, they must have the protocol to do it in a very shorter time. There are many papers in which they have described that they can do the MRI within 6 minutes, and if you can do this is the best thing. So a very common management challenge is the stroke mimics. Almost 30% of the patients who are admitted under the diagnosis of the stroke, they are discharged with the diagnosis of the stroke mimic the next day. So what are the common causes? Common causes are the functional decompensation of the prior stroke, epilepsy, and the migraine. These are the commonest causes of the stroke mimics, and the stroke mimics are very easily and accurately diagnosed by the MRI. So this is one of the example of the stroke mimic. So there is a 37-year-old female presented with aphasia and the dense left-sided weakness. So when CT was performed, CT was unremarkable, and when CTA was performed, CTA was also unremarkable, but the patient was admitted. And the next day when MRI was performed, you can see there is a restricted diffusion involving the right mesial temporal lobe and also the hippocampal gyrus, as well as this pulvinar region of the thalamus. So it was the seizure, which is a stroke mimic, but not the stroke. And you can identify this by using the MRI. So when we shift the MRI towards the CT is widely available. CT can be done very, very fast. And the CT, we can identify the ischemic core on the CT by using the SPECT score. In the next slide, we will be talking about the SPECT score. And We can have the CTA also, and CTP can also be performed, but the current recommendation is this, that if the patient comes within the 6 hours, we do not do the CT perfusion because it is more confusing. It does not give an added information to the to select the patient for thrombolysis and also for the endovascular treatment. And it should all be performed within the within 5 minutes. So if we use the CT for the stroke imaging, first of all, we do the non-contrast CT. Non-contrast CT is done for the SPECT scoring, which is used to identify the ischemia, early ischemia. Then we go for the CTA. CTA is done to identify the large vessel occlusion, which is, in this case, you can see there is a left M1 occlusion. And then CT perfusion is performed to identify the core and penumbra. This is just similar to the MRI. But in MRI, we have the advantage that we can identify the core by using the DWI. However, here the penumbra is the same, that Tmax more than 6 seconds, the yellow is the penumbra. However, core is identified by the relative cerebral blood flow less than 30%, and the red color is actually the core. So SPECT scoring is the Alberta Stroke Program Early CT score, and this is for MCA infarcts, and the MCA territory is divided into the 10 regions, and the M1, M2, M3 is at the ganglionic level, 7 cortical regions and the 3 deep regions. The cortical regions M1, M2 and M3 are at the ganglionic level, and 4 to 6 are at the supraganglionic level. And then we have the insula and also the caudate, lentiform, and the internal capsule. So what we do is this, that for every inattenuation or the hypodensity, we will subtract 1 from the SPECT score. So the perfect SPECT score is 10 when there is no change, and if whole territory of the MCA is involved, then the SPECT score will be 0. So this is how we do the SPECT scoring, and this gives us the idea of the early ischemic change. So there are certain limitations of the non-contrast CT. We can miss some of the infarctions, which are the early infarctions. For example, in this case, you can see that the 79-year-old female presented in the emergency department with a sudden onset of aphasia. And you can see that there is no change in the CT. Insular ribbon sign is not present, and there is no inattenuation at the gray and the white matter junction. However, when the DWI was performed, you can see that there is a restricted diffusion in left parietal lobe. So here there is an added value of the CTA. What we can do is this, that we can use the raw data of the CTA. The raw data of the CTA has the window which is called the blood flow window. And when we use this blood flow window, you can see this dark area is the area when there is where there is early ischemic changes may be seen, and you can compare this with with a DWI, and you can see that this area is already infarcted, and which cannot be picked up on the non-contrast CT. So this is the added value of the raw data of the CTA. And similarly, this is another example in which the patient comes with the niche score of the 14, and you can see that there is a large white matter disease. So it is very difficult to pick up the inattenuation or the early ischemic changes in this CT. So again, when you perform the CTA, you can see there is a right M1 occlusion, and when we go towards the raw data of the CTA, the blood flow window, you can see the dark area which is showing that right MCA territory is largely hypoperfused. And you can also confirm it by the DWI, and large area is affected. So this is very important because we have to decide about the patient treatment. So how we use the treatment for the treatment selection. So this is the case in which you can see that if the patient comes with the symptoms of the acute strokes, and you can see there is a left M1 occlusion. But when we see the non-contrast CT, there is no change in the non-contrast CT. So how we decide about the treatment? What we do is this, that when we go for the MRI, we see that there is a large, penumbra seen, the perfusion deficit is seen here involving the left MCA territory. And if we do the CT perfusion, you can see that there is also the large penumbra here, and the relative cerebral blood flow is less than the 30% for the ischemic core. So this is the advantage of the CT perfusion, and this is something which the CTP gives us, and we can plan for the EVT of the procedure, EVT of the patient in the case. So there are the different CT perfusion thresholds which are used for the ischemia and the infarction. We are not going to go into the detail. At present, we are using these values. For example, for the infarction core, the relative cerebral blood flow less than 30%, and for the ischemia, which is actually the penumbra, T max more than 6 seconds. So the question is this: can CTP close the gap between the CT and MRI? So there are the different papers. Some of them have described that there is an added advantage of the CTP, and some of them have described that the CTP cannot close the gap between the CT and MRI. However, there was the study which has selected the 35 patients from the DAWN data, in which both CT perfusion and the MRI was done, and they have diagnosed that there is miscalculation of ischemic core almost up to 30 ml in the cases with the CTP. So the CTP cannot close the gap between the CT and MRI. So what are the images recommendations for the treatment of the acute ischemic stroke? So these are the few bullets. We quickly go through these bullets, and I have taken this from the American Heart Association. So in the treatment eligible patients, either for thrombolysis or thrombectomy, brain imaging should be performed within 20 minutes of arrival. And at least in 50% of the patient, they should be done within 20 minutes. And we should not delay the IVTPA for the multimodality imaging, which is actually the CT or CTP. Before sending the patient for the further CT or CTP to see the large vessel occlusion, we actually should have given them IVTPA. And in the absence of the renal impairment by history, it is okay to proceed with the CTA. We should not wait for the creatinine, because we do not want to waste the time. So as far as thrombolytic treatment is concerned, if the patient comes with acute ischemic stroke and within the time window of less than 4.5 hours, we have to rule out the contraindications. And if there is no ICH, no large infarct, one should go for the thrombolysis. And this is one of the guidelines, that use of the imaging to select the patients with unknown onset or wake-up stroke for thrombolysis is not recommended. But I put the asterisks here. It means that this guideline can be changed because the wake-up trial was done in 2018, and in wake-up trial, they used the MRI to identify the patient for the thrombolytic treatment. So in the MRI, if there is DWI and the flare mismatch, like in this case, you can see there is a restricted division in the DWI. However, there is no change in the flare. So this patient is the candidate for the thrombolytic treatment. However, in this case, when there is no mismatch between the flare and the DWI, this patient is out of the window for thrombolysis, and we do not thrombolyze this patient. So this is the workflow. It's the simplest form. Like if the patient come with acute ischemic stroke, we do the non-contrast CT to rule out the intracranial hemorrhage. If there is hemorrhage, then we send the patient to the neuro ICU. If there is no hemorrhage, then we should start the parallel workflow, and if the patient is within the 4.5 hours window, we should give IVTPA and then send the patient for the CTA to look for the large vessel occlusion. So how the imaging in the endovascular treatment? So early window trials are those trials in which the patients are selected within the 6 hours who come to the emergency department within the 6 hours of the acute onset of the stroke symptoms. So these are 7 trials, and you can see that they use the non-contrast CT, CTA, perfusion imaging, and also the MRI in the few of these trials. So what are the imaging guidelines for EVT candidates who presented less than 6 hours? Again, American Heart Association guidelines, non-contrast CT and the brain CTA level 1 evidence. Next CTA can also be done to see the arch. And perfusion imaging is not recommended in the early time window of less than 6 hours. First, it was included and then it was removed. So for now, this is not recommended in the early time window. So the late window trials are those trials in which the patient are selected who come late between the 6 to the 24 hours. So we have two trials which were completed few years back, Diffuse 3 and Dawn trial. And in the Diffuse 3 and the Dawn trial, they have selected the patient on the basis of the core and the penumbra. And these are the values: the core less than 70 ml and the penumbra more than 15 ml, and the mismatch is 1.8. As far as Dawn is concerned, there is a complicated, method of patient selection. So both of these have done completed a few years back. So the image guidelines for the EVT candidates between 6 to 24 hours from the American Heart Association: non-contrast CT, brain CTA, level 1 evidence, neck CTA can be done for the arch, perfusion imaging or MRI that should be done if the patient comes within the 6 to 24 hours. This is also the level 1 evidence. So this is the acute ischemic stroke imaging workflow. After the detection, initially I told you that the initial workflow. So when the CTA, the patient sent for the CTA to detect the LVO. If the LVO is positive and the patient is within the 6 hours window, we send the patient directly for the EVT. However, if the patient is with LVO identified and the patient is with 6 to 24 hours time window, then we should perform the CTP and the MRI. This is according to the guidelines, and then we send the patient for the EVT. If the no LVO is identified, then send the patient to the neuro ICU. So acute ischemic stroke due to the LVO, a few of the facts: we have 8 positive trials, 7 published in the NEJM. With a 6 hours time window. Hermes collaboration data already published in Lancet, and according to this data, there is no subgroup where treatment is not effective, and the guidelines are already established. So the guideline is the same, that advanced imaging in the early time window is not recommended. So the only thing which currently works for the acute ischemic stroke is opening up the occluded vessels. Everything else is just the steps along the way. Determining the size of the penumbra does not improve the outcome of the patient. Figuring out that the NIH-SS is 17 or 19 does not improve the patient outcome. The only thing which improves the patient outcome is to open up the occluded vessels. So we should do it, and we should do it very fast. So now there are few points regarding the neuroimaging in different population, like in the young patients. So if the young patient comes with acute ischemic stroke, we need to find out everything. So we need to find out everything from the head to the heart. We should touch every modality: non-contrast CT, CTA, head and neck, MRI with all the sequences, EKG, echocardiogram, lab assessment for the lipid disorders, atherosclerosis. If the multiple vascular territories are involved, diagnosis would be vasculitis or embolic. So the management depends upon the diagnosis. Once the diagnosis is made, then the management is the same as in the older patients. So few points about the neuroimaging in the pediatric population. The incidence of the pediatric stroke is 2 to 13 per 100,000 per year. And due to the arterial occlusion, we have the 50% of the ischemic strokes. Now, the most important thing is this, that disability is about 60% and mortality is 5%. And there is, in the 2/3 of the cases, there is a recurrence in 5 years. So it is very important that we need to aggressively treat the pediatric stroke, as well as we need to find out the cause very aggressively. So we can have the neurological deficits on top of it, we can have the cognitive and behavioral issues as well as the epilepsy. So what are the challenges in the childhood acute ischemic stroke? The delayed diagnosis is one of the problem, which is not seen in the adults. So the mean diagnosis time is about 24 hours. And the challenges in the imaging, because MRI is the preferred modality rather than the CT in the childhood acute ischemic stroke population, because stroke mimics are very, very common in the childhood population. About 50% of the stroke is due to the mimics. So there is a problem, obviously, in the 24/7 availability of the MR, and then there is a bottlenecks regarding the sedation and the GA. And also, we have to identify the stroke etiology as well. So the childhood causes of the acute ischemic stroke, we have very diverse risk factors. The most important are the arteriopathies, congenital heart disease, systemic illnesses, infections, like in chickenpox. And in quarter of the cases, we cannot find out the causes of the acute ischemic stroke in the children. So the stroke protocol in the childhood is different. Obviously, the MRI is the preferred as the stroke mimics are common. It is important to have the separate stroke code protocol for the children in any hospital. And in the acute cases, we have to go for MRI with this protocol, in which we do the DWI, axial, GRE, T2 star to find the hemorrhages, MR angiography, and also the axial and the flare T2 to find out the different etiologies. If the patient comes with a subacute and the chronic infarct, then we need the more detailed workup, in which we can have the perfusion imaging, or we can have the vessel wall imaging. Now, there are two examples. So these are my own examples. This is the 16-year-old boy who presented with a childhood ischemia. You can see that this was the initial CT, and it was very old. The patient come to us very first time in this when he was 16 years of age, and already he has established infarct, and there is a leukomalacia you can see here. So when we do the catheter angiogram, now the patient come with the history of recurrent attacks of the TIAs, and also with the seizures. So when we do the catheter angiogram, you can see that there is a bilateral distal ICA cluen with the recruitment of the vessels. And this is a typical picture of the moya, and also the posterior circulation is supplying the anterior circulation. So my next example, this is also from my own hospital. 15-year-old schoolgirl presented in the ER with a sudden onset of the right-sided weakness and the loss of the speech for 6 hours. She is a known cardiac patient with the restrictive cardiomyopathy and already taking the anticoagulants. So the NIST scale was 17. So this was the CT, and the SPECT was 10. So we did the catheter angiogram directly. We did not go for the CTA because this patient came many years back, and some of the doctor who saw the patient at the ER, he rushed the patient directly towards our department. And you can see this is left carotid, and there is appears to be the left ICA totally occluded. And you can see that after the mechanical thrombectomy, the whole vessel is restored. It is not the perfect result, but it is TK2B result, which is very good in the pediatric population. So this is the CT after 8 hours. And this is at discharge, and you can see the patient which comes for follow-up at the 90 days. And you can see the patient has regained the power 5 by 5. So a few of words about the stroke mimics. I have already told you that 30% of all the patients who come to the emergency department with a stroke, they are the stroke mimics, and these are the common causes. So I directly go towards the cases. So the first case is 87-year-old woman, and she come to the emergency department with some expressive aphasia and also with some visual problem. So the important point is this, that she is the patient of paroxysmal atrial tachycardia, and she has the similar episodes of visual episodes which happens once every month for many years. But we have admitted the patient because there is a change pattern, and also because of her age. In the ER, there is a normal clinical examination, only there is a high blood pressure. When CT brain was done and the CTA was done, both unremarkable, she was admitted, and the next day she has the same episodes which last for 30 minutes and then resolved. So this is the imaging. You can see the CT is unremarkable. CTA was also unremarkable, which is not here. And when you see the perfusion imaging, you can see that there is decrease in the cerebral blood flow and the volume involving the left hemisphere, and there is increase in the MTT and the Tmax in the left hemisphere. So it is involving the not a single territory of vascular territory, and keeping the previous history, we label it with a migraine. because it is not patient is already having the same episodes. So the another finding is this, that Tmax is only moderate. It is not up to the level where we can label it as the stroke. So here we can have the rapid, but I deliberately do not add the rapid because rapid is not available in many of the countries, especially in our country. We do not have the rapid software. Therefore, we need to rely only on this kind of the perfusion imaging. So my second case is the 15-year-old man, and he presented with acute onset of the right-sided paresthesia with some of the speech problem. So the paresthesia pattern is different. It started from the face and goes then downward. And it was the first episode, so he was admitted. And when we performed the CT, it was unremarkable. CTA was also unremarkable. There is no large vessel occlusion. And when the perfusion imaging was done, you can see that the cerebral blood flow is mildly decreased, and cerebral blood volume appears to be normal, and there is increase in the MTT, Tmax, and TTD. The whole left MCA territory appears to be hypoperfused, and we were thinking to thrombolize the patient at the time. But at the same time, we were very confused because of the symptoms of the paresthesia, which started from the face and going downward. And secondly, with this large hypoperfusion, the patient does not have any large vessel occlusion on the CTA. Hence, the thrombolysis was not done, and he was diagnosed to have the migraine. So these are few, and the next day the patient has had an MRI. So these are few of the different findings from the different patients, not from this patient, of the different MRI findings in the patients with the migraine with aura. And you can see that in the DWI there is nothing. You can see it's unremarkable, but there is hypoperfusion in the perfusion imaging. And when you see the MRA, you can see that there is a non-visualization of the distal MCA branches, which is one of the findings you can identify in the patients with the migraine and aura. So patients with the migraine with aura more often presented with a perfusion deficit involving more than one vascular territories. And also the patient frequently show a few of the things in the MRA, that is the non-visualization of the distal vessels, or sometimes the MRA is unremarkable. So the last case from the mimic is 81-year-old man. He presented with a polytrauma, and he was previously, he is the known case of the atrial fibrillation, so on the anticoagulation. And because of the suspected to have the ruptured spleen, he was admitted. 2 days after the admission, the stroke call for the left-sided weakness. So the CT and CTA was performed, and you can see it is unremarkable. So the CT perfusion was done, and you can see that there is increase in the cerebral blood flow and the volume involving the right parietal and the occipital region. And there is also some of the hypoperfusion in the right motor strip also, and the MTT is reduced. So these findings are giving us the mixed picture of the hypoperfusion and the hyperperfusion, which can have the we can have the differential diagnosis of the seizure. When further MRI was performed the next day, you can see there is a hyperintensity involving the right parietal region. And when the brain PET scan was done, it found to have the primary brain tumor. So his treatment was started. So there are, a few of the findings which you can, on the basis of the CT perfusion imaging findings, you can differentiate between the seizure and between the stroke. So in the seizure, there is increase in the cerebral blood flow and the volume, and decrease in the MTT and the Tmax. However, these findings are reversed in cases of ischemic core and the penumbra. In the penumbra, cerebral blood flow and infarct both reduced, but as compared to the cerebral blood flow in the penumbra, either the cerebral blood flow is maintained or it is higher. However, cerebral blood flow is always reduced when the core is already infarcted, and MTT and the Tmax is always on the higher side. So my last, few slides about the neuroimaging in the advanced atherosclerosis. So I directly jump to the example. So these are two, imaging modalities which you can use to identify the intracranial atherosclerosis. The first, this is vessel wall imaging, and this is TOF MRA. So you can see that there is a concentric, contrast enhancement of the distal part of the carotid and MCA and the ACA. And when you compare it with the MRA on the left side, you can see that there is the thinning of the MCA and the ACA. So this goes in the favor of the diagnosis of vasculitis or atherosclerosis, and it appears to be vasculitis in this case. So the next example, you can see that this is also the TOF MRA, and you can see that there is a focal narrowing and the disease involving the right vertebral artery. And when we compare go for the vessel wall imaging, you can see that there is enhancement at the exact area where there is a focal narrowing. You compare with this area. So this is the case of the intracranial atherosclerosis, because this is the location is very common for the intracranial atherosclerosis. So this is very a good table which I took from one of the one of the journal. So in atherosclerosis, you may have the stenosis or not. The wall thickening may be eccentric or concentric, but mostly in atherosclerosis it is eccentric. The location of the intracranial atherosclerosis on the vessel wall imaging is usually the distal carotid and the distal vertebral. Enhancement or may not be seen. So by using the vessel wall imaging, you can identify all these conditions. So the background is this, that intracranial atherosclerosis is very, very common in the Asian population. It is the less common in Americans, and a patient who presented with the unknown cause or the cryptogenic stroke, the 40% of those patients, if we go for the vessel wall imaging, maybe we can identify the cause of the stroke in those cases as well. So these are the technical background methods. We can use the CT angiography. Both CT and CT angiography can identify the calcification, luminal narrowing. In many cases of the mechanical thrombectomy, you can see the intracranial atherosclerosis by identifying the luminal narrowing. Now, technically, the MR angiography and the MR vessel wall imaging is performed, and both of these, MRI modalities can be used to identify the luminal narrowing as well as the vessel wall changes. And in the vessel wall MRI, we have to see the dark blood signal or the dark cerebrospinal fluid signal. And it can perform at the 1.5 Tesla MRI very well. However, 3 Tesla MRI, when used, it gives us more detail and enough signal. And both we have to do the before and post contrast, and there is a gap of 6 minutes in pre and the post contrast. So this is one of the image of the vessel wall imaging, which is T1 weighted turbospin echo black blood, and you can see that the vessel appears to be black and surrounded by the CSF signal. So this is MRI protocol technically, which we use for the vessel wall imaging, and I have described it earlier. And there are some pitfalls also. You can see that there is an enhancement also, and also the signal for the vessel, but you must know that this is the area for the venous sinuses, but not the arterial area. So you must aware those regions and the areas where there is a slow flow. So slow flow blood and the difficult areas are the carotid canals, because we have the venous plexus in the carotid canals and the small vessels. In the small vessels, the flow is slow. So the interpretation of the vessel wall imaging is difficult there. So this is also one of the examples in which there is a distal vessel showing some of the enhancement, but when it is compared at the top, you can see that there is no real enhancement. So similarly, this is cavernous sinus, and showing the false interpretation, and when you compare it with the top, you can see the signal is due to the venous flow. So intracranial atherosclerosis, it increases with age. The propensity increases with the age. So the typical locations, you can see that these are the bilateral vertebral arteries, and you can see vividly the enhancement. So this is typical location, and more vivid enhancement is seen in the vasculitis. So it may be vasculitis or atherosclerosis. Similarly, the distal ICA showing the enhancement here. And this is atherosclerosis. So one of the example in which there is a left M1 occlusion and there is a large penumbra. We do the thrombectomy to and did the recanalization. The next day MRI was done and there is very little tissue injury. But when we perform the vessel wall imaging, you can see that this was the site where there was a thrombus. So there is no enhancement. But later on, when after the thrombectomy it was performed, you can see the enhancement, which tells you about the vessel wall injury there. So the last slide, a few of the take-home points that in the vessel wall imaging, we have to report that is there any change in the vessel wall, what is the location and the enhancement pattern. Eccentric or concentric, you may describe it, but this is not important. So thank you very much for your attention, and you can email me any comments and the question at my email. So thank you.
Saima, thank you very much, Saima. Saima, thank you very much. I love your tables. These tables are beautiful, wonderful tables.
Thank you.
For the ecocentric, centric, do you mind sharing these tables with us?
Yes, and these are not my tables. I have a very good, literature review as well. I can share with Ahmad. There is a very good 2 or 3, PDFs are available. And even one can have the CME accreditation, few points if they go through the literature. They are available at the radiographics. I took the tables from there.
Ahmad, any questions?
Thank you, Dr. Saima, very much about information. If anybody has any question, you can type in Q&A.
The vessel wall imaging MRI is very interesting. It's very interesting technology.
Yes, but we can have a full lecture on this. This is just, just to give the basic idea. So previously my lecture was very, it was focused towards the CT findings and towards the CT perfusion. So MRI was not included. So I think because MRI has few of the advantages, and we should know also about the MRI in our part of the world. And now the people are using portable MRI machines.
So the team in Idlib Center, they have a 16 slice CT, and they are functioning with 16 slice CT.
Yes.
So they do thrombolysis. We are in the process of getting angio suite. We are getting 62 slice, where we'll select cases to do CT angiogram. But if you want to talk about working in a low resource, that's in northern Syria, and the team is very dedicated.
Yes,
that makes it different. Makes difference here.
At least CTA should be performed. This is very important. CTA should be performed at least there, because we can have, we can draw, a lot of information from the raw data of the CTA. So this is important. It clears your mind that what you are going to do. So many of the queries. So the CTA is very important. I was just, talking to the Ahmad that the machine is already installed. So the mechanical thrombectomy is already started in Syria.
In the process, we're getting angio suite, and there's a group of interventionalists going after Ramadan, inshallah, to do more training. And we're going to start it with a cardiologist, and slowly after that with a neurologist.
This is the
neurologist and cardiologist.
Yeah. Because in our country also, the lot of cardiologists are doing mechanical thrombectomy. So I am also supporting them, but because at least somebody is doing. in one of the largest province where nobody was doing any thrombolysis or there was no stroke unit. One of the cardiologist, he has built a private hospital, and I asked him that you should start the stroke unit, and he has started the stroke unit. He's the cardiologist, but I am supporting him. At least he has started there.
Inshallah, you will us in North Syria, Dr. Saima, inshallah.
Inshallah, I'm looking forward.
Wonderful. Saima is a very active member in the MENA, as you know, does a lot of educations, webinars. The monthly webinar, which I send it to you, is just a lot of efforts from Saima, Dr. Saima.
Thank you so much. I just want to do, anything for, in our for our part of the world. And I wish that we should have more attendance and, more people should be attending, more should be taking the participations, and, the learning process, it should be, somehow we should, motivate people towards learning and this stuff. This is, I wish, and I try my best. And you are the source of motivation.
Astaghfirullah. You guys inspire me. So your presentations will be recorded. The people who could not attend will attend it. So it will be broadcasted. And many thanks to Sams and Dr. Ahmad Mohabbatin. And
thank you so much.
MashaAllah, there's a big system of educations. There is a simulator lab in northern Syria now. We are building a simulator lab for everything. And they asked me about the interventions, what simulator we need for interventions.
Okay, I'll get the video and I'll send soon. I'll send you soon. Inshallah. Thank you so much.
Thank you very much, Saima.
Thank you, Dr. Saima.